long walks on the beach.
Good. So you're filming now? Okay, good. So I'm Jerry Hesch. I'm presenting a workshop in New York, and this is September 23rd, 2018. And we have Adrienne, who is a yoga and Pilates instructor. And she presents with a very rigid pelvis. I cannot create side glide mobility through her pelvis. And now I'm attempting posterior rotation, and it feels like the block of granite. There's no give there. There's no give here. Now lie on your stomach, please. When we palpate her sacrum is posterior in relationship to the PSISs. And when I try and spring her sacrum, nothing. When I try and spring the ilia inferiorly, there's just no give at all. And the same thing with the superior glide. And I'm putting 30 pounds of force, which is a reasonable amount of force. And I'll demonstrate those spring tests on another person. But the other presentation that she has is that also at L5, she's not going to move. That's going to be in hyperextension. And then at L4, you can see that I can create spring mobility through the body. And then the upper T-spine, she's going to hyperextend. And here it is right here. There's no spring right here at T3-4, as opposed to below that, you can see that I can take up the slack and spring the body. Now lie on your back. That also manifests in the front of her body, the mid portion of her sternum, and ribs 3 and 4 will be very tight because the sacrum is essentially posterior, causing her to flex, but the body counteracts by hyperextending at L4-5 and hyperextending at T3-4, but also ultimately hyperextending at the OA joint. And so I'm on the lower body of the sternum, and she has good mobility. And we get up towards the mid to upper body of her sternum, and that becomes very rigid, okay? So let me take your glasses. And the other finding is that there's no traction. When I apply traction on the temples, that isolates upper cervical mobility because the upper two joints are right under the earlobe. All the other cervical facet joints are in the back. And when I try and create traction, I should see her feet move up and down, but I cannot induce any traction. And you've been aware of your body being very rigid since you were 20. And you described a fall doing a gymnastics maneuver.
Right, I was trying to do a handstand.
Trying to do a handstand?
Flipped completely over onto my back.
So you fell onto your back. And that might be the incident, or it might be an earlier fall, like if someone pulls a chair out from behind you. You don't recall anything like that. Alternately, it could be delivering a big baby. Haven't done that. Okay. Alrighty. Very good. So we're going to treat you, but I thought it would be good to contrast and show mobility in somebody else. So if I could borrow you, Jennifer, and stay close by, we'll get you back on the table and treat you. So I'm going to do a superior spring. See how freely mobile that is? I can take up the slack to an end point. I can then add a spring test. There's additional give in that joint. And the same thing with an inferior glide spring. See how free that moves? I'm on the sacrum. I load it, and it springs. And you can see that that force distributes throughout her body. Okay? So thank you very much. And the treatment for a posterior glide sacral fixation, which is certainly an unphysiological motion, is to have the person lay prone on this 2-inch by 4-inch by 8-inch foam. It's open cell foam, so it gives a little bit. It's not rigid, but it becomes rigid. It conforms to the shape of the body. So let's have you lie on your stomach with those under your pelvis. So it's just right under the bony pelvis in the front. Very good. And we'll leave that there for 5 minutes. And after that, I'm going to just take up the slack through the sacrum, if I can, and I'm going to lean on that sacrum with 30 pounds of force. I'm going to do that for 5 minutes. Okay? So we can stop filming now and we'll come back after treatment.